Well, it's really a great pleasure to be here today. It's a fabulous event, 30-year celebration, and I must say, like Eileen, I started using the CANTAB back close to the beginnings of the development of CANTAB, and it's been fabulous. We've continued to use it in nearly all of our studies since I went back to Australia. So I'm going to show you a little bit of history first, and then talk about trajectories. And I'm really going to focus on the notion of trajectories. It builds a little bit on some of what Eileen has discussed, and some of the previous speakers have discussed. The trajectories are really very important when thinking about things like what are the markers relevant to the disorder, what things should we target in terms of cognitive remediation, what things might be changing over time. And I'm going to try and place the brain structural changes that we've found in the context of cognitive changes. I'll touch on resilience only briefly, but it's an area that we're looking at currently. And then I'm going to finish by talking about a childhood schizotypal study that I'm very excited about. So we heard from Trevor this morning about translational research, and we've done a lot of work in Melbourne at the left side of this, looking at clinical neuroimaging and cognitive features of the disorder. Increasingly, we're doing work to the right of that, trying to go beyond just mapping and trying to understand what's going on in terms of the neurobiology of the disorder and what might explain what's happening. And we're doing this both in schizophrenia and in autism. That mouse is moving. Some history. So when I started this work, I was actually working as a social and epidemiological psychiatrist and doing research in those areas. And it was observations of patients in Camden where I did a survey that really informed the notion that something is happening in the brains of these patients. Here's where I started that work. This is Frian Barnet Hospital. I don't know how many of you remember this hospital. Colney Hatch Asylum, went through various iterations in terms of name. It's gone through one further change in terms of name. And I'll just show you in the next slide. Just to say here, it boasted the longest corridors in Europe, and registrars would use a bicycle to get from one ward to the other in the evenings. And when Maggie Thatcher visited, because it was in her constituency, that bit of the corridor would be painted. Frian today. So I visited Frian on Saturday because I was really very curious to see what had happened. And now, as you can see, it's gone through another metamorphosis. It's called Princess Park Manor. And for £1 million+ you too could be a resident of Frian Hospital. I do think some of these people are institutionalised, by the way. These are the patients of Frian Hospital, and I took photos of them back in the 1980s. The top right-hand shows patients that have been in hospital for about 20 years. They manifest really quite severe and striking negative symptoms of the disorder. The gentlemen at the bottom are manifesting catatonic features, including echopraxia and also dystonia, a sustained contraction of the muscles. Has anyone ever seen what's that man on the left there? He's manifesting psychological pillow. His head is above the bed and he maintains that posture for hours at a time. Another catatonic symptom. It was really these kinds of observations that drove some of the hypotheses about what might be happening cognitively in this disorder. And that led to some of the initial studies, and Trevor has already flagged these. We worked together with Trevor and with Adrian Owen and others to look at a comparison of patients with chronic schizophrenia to those patients with frontal lobe lesions or basal ganglia disorders, and our patients were quite dramatically impaired. So, when I went back to Melbourne, we were in a really great position, as at that time, in the early 90s, Pat McGorry, Alison Young, and their team were developing the notion of high risk for psychosis individuals, and it afforded us the possibility to examine people before anyone became ill, to follow them over the transition to illness and to assess them both cognitively and in terms of brain structural changes. So I'm going to try and marry the two, not necessarily directly, but show you how those might come together. And one of the important issues here is that the context in which mental illnesses are developing in young people is that what you see here. It's these disorders, and you've seen this graph earlier, these disorders are emerging in late adolescence, early adulthood, in contrast to neurodegenerative disorders that have their greatest burden later in life. The context here is different. Adolescent maturation of the brain is a very different thing compared to what's happening at later stages in the normal brain, and we need to keep that in mind in thinking about the abnormalities that we see. So here Nitin Gogte, Judith Rappaport and colleagues have demonstrated that there's a gradual change in grey matter thickness from starting at the back of the brain at around age 4, moving forwards and downwards and finishing in the frontal cortex and superior temporal gyral areas, suggesting, and that is over the adolescent period up to about early adulthood, suggesting that there's a very dynamic change occurring. And when we're thinking about brain structural or other changes in psychotic disorders, we need to take account of that. Cognition is also maturing. And here we did an experiment with a task of inhibition. It's actually a task called the MSIT. It allowed us to look at individual subjects, and we did this for the purposes of a science ABC program. And the son and his father were scanned and also tested on the task. The son, despite thinking he'd outperformed his father, did badly, and was also using a lot more brain in order to do that in the region of the cingulate. So an interesting example. So at the earliest stages of the psychosis, and these are the ultra-high risk criteria that Magori and Jung developed. And people were identified because they were presenting as things weren't going quite right, they were not performing well, their behaviour had changed, and they were experiencing attenuated symptoms of psychosis, or they also had state or trait factors such as a family history or schizotypal features. And almost 40% of those individuals made the transition to psychosis over about 12 to 18 months. This was quite important because it really was unique in terms of looking at the transition to active illness. The first study for us was informative and really led to us thinking about longitudinal changes. And here is that study undertaken by Dennis Velakoulas as part of his thesis. At the time, he looked at all of our data. We collected quite a lot of data, almost 500 subjects, looking at hippocampal and amygdala volumes. And that arrow in red there shows the progression. We're looking at across stages of the disorder. Just focus on the darker coloured bars which represent hippocampal volume. There's a significant reduction in hippocampal volume in chronic schizophrenia, the very left bar there. As you move more into first episode schizophrenia, the left hippocampus is smaller but not the right. And first episode schizophreniform with less than 6 months of illness. The left was down, but not quite significant. And when we go back to the high-risk pre-psychotic, so those at-risk individuals who subsequently developed a psychotic illness, hippocampi didn't appear to be affected. Now, volume doesn't mean that function is normal, but we'll come back to function in a second. But it was that study that really led us to think, well, is it possible that there may be progressive changes? And we started to think about trajectories of change. Now here, this is really a mock-up of potential trajectories. The top one being normal neurodevelopment, and then below that, neurodevelopmental lag, neurodevelopmental arrest, and neuroprogression or neurodegeneration. If you look at that dotted line, at that particular point where the three lines intersect, and you measure them with cognition, brain imaging, physiological measures, or whatever you like, really, those three individuals might look identical, leading you to conclude that they're very similar. But clearly, it's only when you map the trajectories over time that you see that they're really quite distinct. I'm going to show you examples of each of those trajectories, both in terms of brain imaging and cognition. So this was our first study, which after about 2 years got published in the Lancet. You have to have a degree of resilience when you're undertaking research in this area. But it has been a very influential paper, and it really changed thinking in terms of progressive changes over time. And people are still trying to work out what those changes might mean. That's not the topic today, but I think that's important to be looking at. We identified changes over the transition to illness. So these are people scanned just before they became unwell, and then again after, and this is the difference. This is what happened over time. Inferior frontal, medial and inferior temporal, as well as bilateral cingulate regions were changing dynamically with the onset of illness. And it led us to look at a range of other brain regions that might be changing. I'm just going to show you a few examples that are relevant to cognition. So here we looked at the neocortex. We looked at every point on the surface of the brain and looked to see where it moved to between time 1 and time 2 scan. The panel on the left is first episode schizophrenia, scanned within the first few months following onset, and then 2 to 4 years later. And the middle row there shows the changes in first episode schizophrenia, with significant findings in prefrontal cortex, particularly superior frontal. The row above that are normal controls, and what you see there is similar pattern of change over time, but to a much less degree. And when you correlate the change in the controls versus first episode schizophrenia, it's going at about twice the rate in first episode schizophrenia. It suggests an accelerated normal pattern of neurodevelopment. Importantly, this was across the whole brain. We think that the reason it's significant in the frontal lobes is that this is the region that is changing most at this stage of brain maturation. In other words, there's likely an interaction between the onset of the disorder and in the stage of brain maturation which is relevant. And this pattern has already begun in the pre-psychotic individuals, which are the middle row on the right. So again, very dynamic processes occurring at that point. So it led us to think about developmental trajectories in cognition. And here is some CANTAB neurodevelopmental trajectories that we examined in terms of spatial working memory on the left and attentional set shifting on the right. Previous speakers have spoken about these in some detail, so I don't need to explain the tasks. But here we've flipped errors on their heads, so it's performance rather than errors. So what you can see there is that 8-year-olds are poor in doing the task. 65-year-olds are poor at doing the task, not necessarily for the same reasons. And optimal performance is actually between age 25 to 30, which is fairly late when you think about it. And these have been controlled for IQ. By contrast, attentional set shifting appears to already have matured by puberty. And this seems to be a very early maturing ability. We think that taking account of these different maturational trajectories is important when you think about the abnormalities and particularly what might be preserved at the beginning of the illness. So if we take spatial working memory in our patients with schizophrenia and we look at them across stages of the disorder, what we see is that across all stages from before onset through to chronic illness, which are the 3 lines at the top there, with the circle around them, show a very similar deficit. And when we follow them up over 7 to 10 years, that deficit is stable. There's no particular change. So it's a stable deficit over time. The 2 lines below that are the ultra-high risk who do not develop psychosis and normal controls. Here we're looking at errors and different stages of the task. So it suggests that this ability, which seems to be relevant to regions in the prefrontal cortex, such as DLPFC, are already abnormal before illness onset and remain stable over a decade or so. It's possible that the onset of psychosis or its prodrome is interrupting that maturational trajectory and leading to an arrested development. In the context of cognitive remediation, it's likely that this would be a difficult task to remediate because the substrate has not adequately matured by the time of onset of the disorder. By contrast, when we look at the attentional set shifting task, we see a slightly different picture. And here, attentional set shifting is not significantly different between controls and first episode patients, particularly when you control for the deficit in spatial working memory. 7 to 10 years later, in these same individuals, there's a dramatic drop-off in their performance, and I know that this contrasts with some of the data that Eileen has published, but interesting, I think, in that regard. And this would be consistent with some of the progressive changes in the brain regions I mentioned earlier that we're seeing, and suggests at least neuroprogression. We don't know what the pathology underlying it is, and we need to be looking at things like various things such as apathy, amotivation, medication, drug effects, and we've been looking at all of those things, but again, there's not time to present that. The other task which fits into this hypothesis is visual paired associates. So you've heard about this task, good probe of hippocampal integrity. And these are some data from CANTAB, which are very useful and show us again that the maturational trajectory for this task is early. So the number of errors is low after childhood. And again, when you reflect on the hippocampus being normal at the beginning of the illness, or at least in our data, it's interesting to see that when you look at the left side of that graph at baseline, there's no difference in performance on this visual paired associate task, including in the pre-psychotic individuals. When followed up over 7 to 10 years, however, we see a significant increase in errors in that group that have schizophrenia outcome specifically. Again, suggesting that there seems to be a distinction between those tasks that have matured early versus those that are still maturing when the disease comes on. And indeed, it prompted us to look with Nitin Gogte in the US to combine their childhood data with our adolescent data to try and get a handle on this. And so the third trajectory that I haven't shown yet is that of developmental lag. Is there any evidence to suggest an improvement in trajectories? And this is the work of Nitin Gogte and Judith Rappaport in the NIH. These are childhood schizophrenia cases scanned from an early age, about 12, through to adulthood, and you see abnormalities in frontal regions, but also more posteriorly. And if you think back on the normally developing brain, childhood schizophrenia is impacting on more posterior regions that are still maturing during childhood. What they also did was to look at the unaffected siblings of these childhood schizophrenia cases. And I've seen the videos of these children. It's a very rare disorder, of course, but they look very similar to my cases of treatment-resistant schizophrenia that I'm treating in my unit, and most of them are on clozapine. What's interesting about the siblings is that if you were to scan them after the age of about 16 or 17, their brains look normal. If you were looking for an endophenotypic marker, you'd have missed it, because actually all the action is occurring back when they were children. And when they were at the very beginning, when they were prepubescent, they were manifesting some similar abnormalities to what was apparent in the childhood schizophrenia cases, but these seem to normalize over time. The next slide shows a movie of the same thing, just to give you a picture of that. But this does seem to suggest developmental lag, whereby there's a normalization from an initial abnormality. And here on the left panel is the childhood schizophrenia cases, and the numbers represent when the scanning occurred, and here are the unaffected siblings. And you can see this apparent loss of this abnormality over time. So it prompted us to work together with Nitin, and here we worked Andrew Zaleski is an electrical engineer that we've employed in our group, and it speaks to the importance of multidisciplinary research. And he's been interested in the wiring pattern of the brain and connectivity. Here he used structural covariance to look at thickness measures across the brain as a proxy measure of connectivity. There were abnormalities, so the top line is the normals. There were abnormalities at age about 12 in the children with schizophrenia, as well as their unaffected siblings in terms of connectivity, affecting particularly temporo-occipital sort of regions. And they were related, there was an association with symptoms of the disorder. Over time, the line in the middle in black is showing a normalization of that brain connectivity by about age 16, which is very interesting because it suggests there may be resilience factors or protective factors that help these children to go back to normal. We haven't yet looked at cognition in the context of this trajectory, but I think it would be certainly very interesting to do so. So it raises the question, when we're trying to look at the relationship between brain structure and cognition, what's the best way to do it? And we've done a little bit of this, and I've got a PhD student working on this currently. But this is some early work that we did, looking at the CANTAB spatial working memory task in relation to cingulate cortex, and here we looked at the morphology or the folding pattern of the brain in the region of the cingulate. The normal male brain shows a left lateralized pattern of greater folding on the left side compared to the right. And that pattern is associated with better spatial working memory performance. In both patients and controls, loss of that lateralized pattern was associated with less or worse ability on the spatial working memory task. So it suggested some kind of link. What's interesting about that morphology is that it's related to things like surface area. And again, Eileen's group have done some nice work looking at thickness versus surface area and finding relationships with surface area. So that is interesting. By contrast, when we looked at thickness measures in the region of the cingulate, we didn't really find very much in terms of spatial working memory, but we did see relationship to symptoms. In red there, what you see is that increased negative symptoms were associated with thinning in the region of the cingulate. By contrast, in the high risk who developed psychosis, by contrast, in the group that didn't develop psychosis, larger thicknesses were associated with higher symptoms of anxiety. Again, it seemed to be some kind of dissociation in terms of symptoms. So thickness may not be the best way, and at one point in time may not be the best way in terms of looking at the relationship to cognition. And indeed, trajectories, I would suggest, is the better way, and looking at change over time, mapping that change over time. The other point to make is that trajectories are not necessarily linear. We kind of assume that they might be, and often that's because we only have 2 time points. But actually, we need a number of time points in order to map these correctly. And these are some summary data by a fellow that worked in our lab for 2 years. Incredibly productive Japanese fellow who published 20 papers by taking all of our data and using his methods in that regard. And the yellow boxes represent the annualized rate of change in the region of superior temporal gyrus and insula in those 2 panels, showing that the greatest changes were occurring at the earliest stages of the illness, particularly the transition to illness. And it led us to start thinking that trajectories may be much more complicated, and certainly the data from Shaw and others suggests that different brain regions might be changing in different ways. So the suggestion here is that if you were to do a time 1 scan at the beginning of that red line, and then again at the second point of the red line, you'll see a significant change. In the same individual, though, if you scan them at the 2 ends of that blue line, there'll be no difference. So what we really need are serial measures to map the trajectory adequately. What we're now trying to do is look at acute relapse and remission of psychotic illness, because we think that relapse and remission may show a different trajectory. You'd expect neurobiological changes as people are becoming unwell. and there's some very limited data in this regard, and it's important to map that accurately. And we're also looking at the possibility that neuroinflammation might explain some of those findings. So in summary, you see dynamic changes which are evident from before illness onset, and you see neurocognitive and functional outcomes that not only can be understood but need to be understood in the context of brain maturational changes. And it's important to distinguish early versus late maturing abilities in this regard. And when you're trying to link, I think, cognition to brain structure, it's important to look at mapping trajectories over time. Now, if I've got a minute or so, I just want to briefly touch on the study that we've been doing with children with childhood schizotypy in comparison to autistic children. So we got together with Bruce Tong, who was emeritus professor, an expert in autism, who had developed together with Renee Tester, a clinical neuropsychologist, the idea that some of the autistic children, supposed autistic children that were presenting to the clinic may have had an alternative diagnosis of schizotypal disorder or schizotypy in children. It's a controversial notion, not everybody believes it, but we've developed an instrument to assess this, which is now published. We've been able to show that we can discriminate autism from schizotypy. The basic issue with the schizotypal children is that they have a very rich fantasy world. They live in their head, and that impacts on their ability to function at school, to function socially, and they're often bullied and do badly at school. Not necessarily, because it can also be a very creative process, having a very rich fantasy world. But often in these kids that present for clinical reasons, they're often inhabited, these fantasies, by monsters. They're often a key figure themselves in these fantasy worlds, and they're completely preoccupied by them. Renee gets them to draw pictures, and then she gets them to elaborate on those. Now, has anyone seen the film Shark Boy and Lava Girl? Anyone seen that? Renee takers? Anyone got small children? Oh, we've got some. Great. I think that shows very well a kid with schizotypal features. So I'm just going to show you a snippet from the movie. Wake you up as well. So these kids often have difficulties at school and are quite bullied, etc. So what we did was to identify a cohort of children that manifest these features. And a PhD student, Harvey Jones, completed his thesis looking at these kids, undertook a cognitive study as well as a clinical study. The paper that's published is the Melbourne Assessment of Schizotypy in Kids, the MASK. So if anyone's interested, just let us know. We have now just finalised and, we're resubmitting a paper that looked at the attentional set-shifting task in these children. So these children were assessed around 6 to 8 or 9 years of age. We did see that maturation of this attentional set-shifting task seems to be occurring around, as early as that. We saw abnormalities in children with autism as well as children with schizotypy. But there did seem to be some differences which emerged in the data. And this is some work that Ahmed Abu Akel, who's at Birmingham University, he came down and worked with us for a few weeks. And he's been assessing schizotypy and autism in the normal population, demonstrating counterintuitively that when you have both features, both autism and schizotypy, your performance on various tasks, including social cognitive tasks, is improved or better. So I said to him, here's our data in these kids, and we had autistic kids, see if you can identify a similar pattern in this study. And lo and behold, the red line are the children that have both schizotypal and autistic features. I'll leave you with that to ponder. If you've got any interesting ideas about it, I'd like to know about it, because I think it's very interesting. In fact, it's interesting also when you look at reversal learning on these children, that seems to be impaired. So they're making more errors on reversal learning, but they're reaching criterion. So it suggests that they may be better able to switch when they need to, perhaps. So thank you. There's a lot of people to thank with the sort of work that we're doing, and it's been fabulous working with Trevor and other people here. I love visiting Cambridge, so please do invite me back. I'd be delighted.